Hi, welcome back for part two of our discussion. So I'm going to do a quick rundown over part one. The nice thing is that this is recorded, so you really don't need me to say this. But we're doing a case presentation on a 26-year-old patient that had outside surgery and came to MD Anderson for possible residual disease versus recurrence. I would highly encourage and recommend for y'all to watch the video for part one. Rachna discussed triage and orders and tests and everything that you need to have done. Christina talked about medical management, and then we had Savannah and Julia talk about surgical treatment and complications. This part right here, I'm going to turn back over to Christina, and she's going to talk a little bit about radioactive iodine. Hopefully we have a little bit more time at the end of this session for some more questions. Thank you.
Hello, and thank you for joining us for part two of this session. For those of you who weren't here during the first part, my name is Christina Bowie. I'm a nurse practitioner at MD Anderson Cancer Center. I work primarily with Dr. Maria Cabanillas in advanced thyroid cancer. So just a brief recap. In the first session, we talked about management of thyroid cancer, which includes surgery, possibly radioactive iodine and TSH suppression. We talked about surgery and TSH suppression in great detail, but we did not talk about radioactive iodine in very much detail at that point. Now, as we stated in the first session, this case was more than 20 years ago. So a lot of the original information is unknown. Like they didn't have as detailed pathology reports back then, I guess. So I looked at the pathology on the patient and there wasn't a whole lot of information, but they did say that there was angioinvasion of this tumor. So I believe that's probably the reason that they made the decision that the patient needed radioactive iodine. And then also back then, way more patients got radioactive iodine than they do now. Just as a side note, medical management changes over time and our recommendations also change over time as we know more. So there are different recommendations for who gets radioactive iodine, but I wanted to simplify things and I just kept the American Thyroid Association recommendations in the PowerPoint, but you'll find other recommendations if you go looking for them. So the ATA recommends that patients get radioactive iodine if they have any of the following things on their pathology report: extension outside of the thyroid, a primary tumor greater than 4 centimeters, distant metastases. And when we say distant metastases, that's anything outside the neck. It is not recommended if they have a single focus of tumor less than 1 centimeter. So we call that a micro thyroid cancer, or multiple areas of tumor that are all less than 1 centimeter and no other high risk features. Then there are some gray areas, and they say, well, you might want to give radioactive iodine if the tumor is 1 to 4 centimeters confined to the thyroid, if they have lymph node metastases, and other features that place the patient in intermediate or high risk categories. And in the first presentation, we talked about risk stratification, what constitutes low risk, intermediate risk, and high risk. And I did say in that presentation that typically only intermediate and high risk patients are going to get radioactive iodine. That's what drives our decision making. But we also take into account age, the pathology report, history of exposure to radiation therapy, family history of thyroid cancer, contraindications. Is there a reason why this patient doesn't make a good candidate for radioactive iodine? Do they have mutations that put them at risk for other types of cancer, etc.? So it's a very individualized decision. Now, going to our case study, before they got the radioactive iodine, we stimulated their TSH, and it stimulated to 54.17. So the thyroglobulin at this point was only 2, with a thyroglobulin antibody of 1. If you were here during the first part of this session, you may remember that when they first came to MD Anderson and they had that large thyroid remnant in place, their thyroglobulin was 16 with a thyroglobulin antibody of 1.1. So it's already dropped significantly. And we did a whole body scan prior to radioactive iodine, which showed uptake in the neck and in an area above the right clavicle. And so this patient did not have a post-treatment scan, which is pretty standard now. If you have radioactive iodine, then somewhere between 1 and 10 days, you're going to come back and we're going to get a post-treatment scan. So I'm not sure what that would have shown. We do that to see if there are additional sites of uptake with a larger dose of treatment. So the patient had their treatment and they came back a year later. And the labs showed a suppressed TSH, which is great because we talked about how important TSH suppression is. Thyroglobulin and thyroglobulin antibodies at this point were both undetectable. And they had another whole body scan, which was negative for iodine uptake. It's also not commonly done at MD Anderson that we routinely monitor with whole body scans now, although I have seen other outside institutions who do routinely monitor with whole body scans. But this patient had one, it was negative. So this patient got radioactive iodine, as many thyroid cancer patients do. And the adverse effects of radioactive iodine that we most commonly see are most commonly chronic dry mouth. Lots of patients have that issue after having radioactive iodine. And if that's the case, we have a whole list of things that we recommend for that. Sialadenitis is an inflammation of the salivary glands. It can be very painful, especially like if you're trying to eat and your salivary glands are salivating. This is usually self-limiting. We recommend warm compresses and it typically resolves on its own. In more severe cases, we may have to refer you to a surgeon and you know, I mean, we have seen patients who need more aggressive management of sialadenitis, but you know, that is extremely rare that it would be that bad that they would need that management. And then potentially an increased risk of developing other types of cancer. We weigh that risk against the very real possibility of having a thyroid cancer recurrence. So in the majority of patients, if we're recommending radioactive iodine, it's because you have a pretty good chance of having a thyroid cancer recurrence. Intermediate risk patients, anywhere from 5 to 20%, depending on the individual situation. And high risk patients, a greater than 20% chance of recurrence. That far outweighs the potential possibility of someday maybe developing another type of cancer in most patients, but we do have those patients who are genetically predisposed to other types of cancer, and so then we have to factor that in as well. But there is that possible risk. Now we're going to talk about transition to survivorship at MD Anderson Cancer Center. These are our guidelines. I don't know if other facilities have different guidelines or what guidelines they use, but these are the guidelines that we use. These numbers that you see at the end, these are numbers that tell us the stage of the patient. Okay, so I'm not going to really go into too much detail there. Just know that the T is for the primary tumor, the N is for lymph nodes, and the M is for distant metastatic disease, okay? Low-risk patients, those are like well-differentiated neoplasms of uncertain malignant potential, non-invasive follicular thyroid neoplasm with papillary, so our NIFT-Ps. These are like precancerous. Or like micropapillaries. If they have no suspicion of disease at 1 year, then we go ahead and transition to survivorship, or we can. Sometimes we keep them longer, just depending on the patient, but that is when they are able to be transitioned to survivorship. Moderate risk patients, those are going to be papillary thyroid cancers, follicular, medullaries. If the thyroglobulin is less than or equal to 1, or stable and appropriate for a patient with an intact lobe, so a lobectomy patient. Or if the calcitonin is less than or equal to 5 with no suspicion of disease on ultrasound at 3 years, that's for medullary, by the way. Calcitonin is a tumor marker for medullary thyroid cancer. So either one of those tumor markers, depending on your type of cancer that is low with no evidence of disease on ultrasound at 3 years, those moderate risk patients can go to survivorship. And then our higher risk patients, the follicular, papillary, medullary carcinomas, They can be transitioned if they have either no evidence of disease or stable disease. So sometimes we transition patients who we, suspect, or maybe even we know they have residual thyroid cancer, but it's been stable for many years and we're just watching it. If the thyroglobulin is less than or equal to 3, or the calcitonin is less than or equal to 50, with stable sub-centimeter lesions, so lesions that are smaller than a centimeter and they are not growing, and they are outside the neck, then those patients can be transitioned to survivorship at 5 years. If they have disease in the neck, we continue watching them because at some point they're going to need surgery for that. So we keep them in our clinics until that point when they get surgery, and then but that might be 10 years. Sometimes we just observe for years until it starts growing and they need another surgery. And then we start the clock again once they have surgery. So this is our guidelines for transition to survivorship, which Johnny and Sue are the ones who run the survivorship clinic. So they're probably much more familiar with this criteria than I am. I have to look at it every time I'm going to transition a patient. Okay, so I'm going to pass the mic off to my colleague Sue, who is one of the people that I just told you that does the survivorship clinic.
Okay, hello everyone. My name is Sue. I work in the survivorship clinic and then also endocrine department. Survivorship, the objectives today I want to discuss is we want to discuss the transition to survivorship, goals of a survivorship, domains of a survivorship, and then patient-reported outcome. We call the PRO questionnaires. So I want to start with the definition of a cancer survivor. So cancer survivor from the American Cancer Society refer to anyone who has ever been diagnosed with a cancer, no matter where they are in the course of their disease. And the National Cancer Institute, NIH, refer to the person is considered a cancer survivor from the time of diagnosis through the balanced life. And there are many types of survivors, including those living with a cancer, those free from cancer. How common is thyroid cancer? American Cancer Society and the NIH most recent estimated thyroid cancer in US 2024 is about 44,000 estimated new cases in 2024. And about 2.2% of all new cancer cases. And the estimated thyroid cancer death is about 2,170. And the percent of a cancer death from thyroid cancer is only 0.4%, which is actually very good for our thyroid cancer patients. Their chance of cancer is still, 44,000, 100, but then cancer death is very, very small. From the NIH, thyroid cancer is estimated number 13th most commonly diagnosed cancer, and the number 6 most commonly diagnosed cancer in women. So thyroid cancer is 3 times more common in women than men. And the relative survival rate 5 years is about 98.4% between 2014 to 2020. So our patient diagnosed with thyroid cancer survival rate is actually very excellent compared to other cancers. Our goals for thyroid cancer survivors, number 1, we will actually monitor for the cancer surveillance and screening, and we will evaluate thyroid cancer recurrence and progression. And many of our patients also, when they transition to survivorship clinic, we also educate the patient the importance of other cancer risk. So other cancer screening evaluation and the risk assessment we provided. If a patient decide to see the provider other cancer screening evaluation, we do refer to the other appropriate team. Number 2, late effects or side effects management. We will monitor for the symptoms that could be side effects of treatment or late complication. So our speakers explained if a patient receives radioactive iodine, they can develop the dry mouth or salivary gland actually issues. Surgery-related complication, we talked about it earlier. Parathyroid dysfunction can lead to low calcium issues, or vocal cord injury, or they have a swallow problem. We will refer to appropriate team like a speech pathologist. Number 3, health promotion and prevention. Many of our thyroid cancer patients, when they actually treat with thyroid cancer, they survive a very long period of time, and then they can also develop other medical problems like a high blood pressure, diabetes, and then cholesterol issues. Those things need to be managed by local provider. Even if you have a thyroid cancer, does not mean that you should be neglecting other chronic disease as well. So this is very important. We also discussed the lifestyle management. If a patient is a smoker, then we talk about the smoking cessation and the moderate amount of alcohol consumption as well too. Psychosocial services, support services to maintain healthy relationship and restore life. We do have social services in our institute, and then if a patient needs any concern, then we can actually refer to them. And the ThyCa, like this kind of organization, and we help each other, the community support as well too. Our survivorship guideline and management at MD Anderson. So this is gonna be maybe slightly different than the Christina mentioned earlier. We have a guideline, so we do follow our guidelines, but this is not maybe not the nationwide guidelines. So your institution might be a little bit different, then take it consideration. So if a patient is diagnosed with a low risk of disease recurrence and the year number 1 to 5, we will monitor history and physical exam annually. And if a patient is diagnosed with a papillary follicular Hurter cell thyroid cancer, we mentioned earlier with the differentiated thyroid cancer that we monitor the thyroglobulin antibody. These are the tumor markers we called. If a patient is diagnosed with medullary thyroid cancer, then we actually monitor for CA and calcitonin. This is a tumor marker for the medullary thyroid cancer patients. And we monitor tumor markers annually, thyroid hormone level annually. So thyroid hormone level has a very close relationship with our body weight. So a significant fluctuation of weight can change, even if despite of you are taking same medicine, same dosage, but then weight increase, sometimes you may need more medicine. And if you have an intentional significant weight loss, your body may need less medicine. For that reason, thyroid hormone checking is very important if you're having significant weight changes, or if you're also hospitalized, having emergency visit, or recent illness, a lot of GI side effect like diarrhea. Those patients need to be monitored thyroid hormone because your absorption rate can be also different as well too. And then we will check the neck ultrasound annually. Year number 6 and up, we will check the history and physical annually until year 10, and then every 2 years thereafter. And then tumor markers and thyroid hormone level annually, and the neck ultrasound every 3 to 5 years. So as long as their thyroglobulin is actually low, their CA calcitonin is low and or undetectable, then we can actually check a little less frequent ultrasound of the neck. Moderate risk of a disease recurrence, so this is our patient. So year number 1 to number 3, and then since this is a moderate risk of a recurrence patient, so this patient still should be followed by our endocrine side, like Christina, she works endocrine side. This is like a more close observation and the close monitoring. So if a patient has no evidence of disease or a very stable disease with a moderate risk of disease recurrence, those patient is eligible to transfer to a survivorship clinic. So year number 3 to 10, we will monitor for the history and physical annually, tumor markers and the thyroid hormone level annually. Neck ultrasound can be monitored for annually until year 5, then 2 years thereafter. And then year number 11 and up, history and physical annually until year 20, then every 2 years thereafter. Tumor markers and the thyroid hormone annually, and the ultrasound of neck can be repeated every 3 years. If a patient is a high risk of disease, history and physical need to be checked annually, tumor markers and the thyroid hormone, ultrasound neck need to be monitored annually. Some patients do have a small lung nodule as a history, but if thyroglobulin is undetectable, and then if ultrasound did not show not a whole lot, then those patients do not need to check the thyroid cancer standpoint. They don't need to check the CT scan every year. That's going to be unnecessary, a lot of radiation exposure and then iodine exposure. So we can check with a chest X-ray if as clinically indicated. Our patient transitioned to survivorship clinic in December of 2019. Patient had ultrasound that at the time, but this ultrasound was compared with the previous ultrasound October of 2008. That's about 11 years interval. So we call the right side of thyroid bed. That's the area that you had a surgical site area. That's what we call the thyroid bed, where the thyroid used to be. So right side of the thyroid bed was clear, no evidence of a disease. There were two lymph nodes, two nodules were noted in the left side of the thyroid bed, measuring about 0.5 centimeter, which is about 1/4 of inch size. And those nodule was the largest one. And then the collarbone area, we call the suprasternal area. There is about 0.8 centimeter nodule were noted. Two benign appearing nodules noted at the collarbone area. And then one of the nodule called the prelaryngeal area nodule measured at 0.7 centimeter. This was previously measured 0.6. 0.7, 0.6 is a 1 pencil dot difference. So no significant difference in that. And then there's no worrisome lymph node anterior jugular territory area. So impression of this ultrasound was a frontal part of the neck called the central compartment. There's some nodules noted, but then no significant difference. And then this can be monitored by ultrasound. That's when she comes up, the next follow-up follow-up visit. There's no enlargement or the worrisome side of the neck or the lateral neck, enlarged lymph node noted. Patient had another ultrasound on neck was done in 2023. This was compared with the 2019 ultrasound on neck. So 3 stable, the small nodules were noted, and then largest nodule was a 0.5 centimeter, about 1/4 of inch size, collarbone area, a little bit slightly towards the right side. And then 2 nodules are noted in the left side of the neck. Measures at one at 0.4 centimeter and the other one at 0.6 centimeter. These nodules were also stable. And then there's a little bit of a prominent, means a slightly, little bit prominence of nodule noted in the left side of the scar tissue area, measures of 1.3 centimeter. But this was still visualized actually previous ultrasound. And then this is the nodule that we did not see prior ultrasound is about 0.6 centimeter on the left side of the collarbone area. And then which can be continued to monitor and appears to be the characteristic of nodule appears to be benign. And the prelaryngeal nodule measures as 0.7 centimeter. This nodule was there before and still the same. And then no side of the neck enlarged lymph node noted. So impression was that this ultrasound was a stable to slightly increase prominence of a frontal part of the neck or the central compartment nodules, which can be continued monitored by ultrasound. And then side of the neck, lateral side of the neck, no worrisome lymph node enlargement. So fortunately, our patient being monitored by blood work as well, even if we didn't do the ultrasound 2019 to 2023, but we've been monitoring, follow our guideline, the survivorship guideline. We've been monitoring the tumor marker called the thyroglobulin. Thyroglobulin has been undetectable 2019 all the way up to 2024. So that is pretty reassuring. And then thyroglobulin antibody also was negative. So Christina earlier talked about the importance of a TSH suppression. So our patient 2023, 2024, the TSH level of a 1.4, 1.45 was appropriately suppressed. I mean, I don't want to call suppressed, but it's low end of normal limit. But then when you look at the 2019, especially 2021, this is not our recommendation of a TSH, okay? So it was not suppressed at all, and that it was abnormal than even normal patients, okay? So it was a 6.05. So for our thyroid cancer survivorship patient, we'd like to have a TSH management. This is gonna be a little bit different than, I mean, when the patient has how many years far out from their disease, their risk of a disease recurrence can be different. So when we actually have a patient with the low risk of a disease recurrence, year 0 to number, up to year number 5, I would like to keep actually their TSH score lower end of a normal limit, like approximately 0.5 to 2. If a patient is 5 years up and plus, if they have a low risk of disease recurrence, we would like to keep their TSH score mid-normal range. And then if a patient is a moderate risk of patient, the year 0 to up to 5, and we would like to keep their TSH score 0.1 to 0.5. Between 5 to 10 years, we would like to keep their TSH score lower end of a normal limit, about 0.5 to 2. And the year plus 10, if a patient is normal and stable, then we would like to keep their TSH score mid-normal range. If a patient is a high-risk patient, then we still like to suppress their TSH year 0 to year number 5. And then suppression TSH should be like a 0.1 or less. And then year number 5 to 10, 0.1 to 0.5. And the year 10 plus, and they're high-risk disease recurrence patient, but they are still very stable, then we would like to keep their TSH score lower end of normal limit. So our patient, we've been monitored by, we call the patient reported outcome PRO questionnaire. We ask some of the patients that sometimes it can be related to symptoms that concerning for thyroid cancer recurrence or disease related the complication or late effect, the treatment effect. Those patients we've been monitoring, and one of the actually symptom patient reported as a symptom is like a hoarseness voice. She rated her symptom as in 2020 was 2022 was a 2, 2023 was a 5, and it continues to progress worse as a 2024 up to 6. Therefore, we refer to speech pathologist for the further evaluation and the treatment, and it can be related to treatment effect or late treatment side effect problem, or it can be something else. So that's why we refer to a speech pathologist. I'm gonna actually have the microphone to Barbara.
Okay. Has anybody in the room seen a speech pathologist or been referred to a speech pathologist? Okay, great. Hope your experience was good. Okay, so I just wanted to start with this diagram. Here's the thyroid gland, and sort of remind everyone that, the thyroid gland, lives in a part of the neck that's very busy. It does a lot. The larynx is here. The larynx is, important for talking. That's what we all think about when we think about the larynx, but also important for breathing and important for swallowing. And then you have, lots of these structures, as Savannah and Julia mentioned, like vascular structures, the nerves, and a lot of soft tissue, fascia, muscle, things like that. And so when we go in here, I say we, it's definitely not me, but when the surgical team goes in there and manipulates these things, things can get pulled, things can get tugged. They do a lot to really try to protect the nerves in particular, but they can be tugged, and occasionally they can be cut. And then also, the soft tissue, as it heals, it gets sticky, it can be adherent. And so patients will come into my clinic sometimes right after, like shortly after surgery, and sometimes like this patient 20 years later with symptoms of, which, oftentimes are some of these things. So globus sensation is a term we have for when you feel like there's something just kind of stuck in your throat. And sometimes patients have that feeling all the time. Sometimes they just have it when they swallow. They may have dysphagia, which is symptoms of difficulty swallowing. Maybe it's coughing and choking with foods or liquids. Maybe it's feeling like foods get stuck when you try to swallow it, or you have to swallow multiple times or wash it down with liquids. We have dysphonia, which is a change to the voice. So maybe the voice is soft, or maybe it's, kind of raspy, or maybe it gets tired the more you talk. And then throat or neck tightness. I actually heard somebody talking about this just today, where it might feel, I've had patients describe kind of a feeling like, someone's hand is wrapped around their neck, or tightness when they move their neck. So these are all fairly common symptoms, but we tend to see them more in women and people who had larger thyroid nodules, bigger surgeries like a total thyroidectomy versus a lobectomy, or like revision surgery. So sometimes why we tend to see more problems after revision surgery is, that area has already been disturbed. So the anatomy isn't always exactly where the surgeons expect it to be. And then you have all this sticky scar tissue in there. So that risk of traction injury and stuff like that goes up. So we have a number of tools in our toolbox, and the kind of assessment, if you see a speech pathologist, the kind of assessment you get will vary depending on what your physician sends you for. But oftentimes it starts with a clinical evaluation, and this is just done in the office. And if it's for voice, the speech pathologist will give you a microphone and, maybe record your voice and analyze the acoustics of your voice. They'll feel your neck. They'll make you move all your muscles as they try to assess what's going on. And they'll ask you a lot of questions about your voice use. And we can kind of get a picture of what's going on there and make some judgments about what might be the problem. Similar with swallowing, if it starts clinically, we'll give you foods and liquids. We'll actually watch you eat. We'll put our hands on your neck sometimes while you're eating. And then we may refer you for more objective or instrumental testing. So a good amount of this is done with a flexible endoscope. Has anybody ever been scoped? Okay, so the lucky ones in the room. It's definitely, I tell patients, it's not painful, but it's unpleasant. We don't like the feeling of a scope crawling up our nose and down our throat, but it's pretty cool if you get to see what's happening when it's happening, because you don't really get to see in your throat every day. But this is sort of what it looks like. You've got the scope just kind of weaving down the throat here. And if we're assessing your voice, we might do something called video stroboscopy. So these are the vocal folds and they vibrate. That's what makes sound. And that vibration happens so fast, you can't see it with the naked eye. So for a woman, it vibrates about, 220 times a second when you talk. And for a man, maybe 100, 150 times a second. So the stroboscopy uses light technology to sort of slow down that vibration, or appear to slow down that vibration, so that we can really analyze what's happening when they're vibrating and why you might be hoarse. And then this is something called FNP-C, which is an endoscopic evaluation of swallowing. So we've got the camera in there. We've got this view down your throat. So like, here's your larynx here. This is green tinted liquid. These are the vocal folds, and that is your airway. And the opening to your food pipe is right back here. And so we can give you this tinted food and liquid and see what happens and get a better idea of what might or might not be working. And then we also have an X-ray swallowing test called a modified barium swallow. Has anybody ever had that? Yeah, same group. So, and that's similar to a FNP-C, no scope in the nose. It's done with an X-ray. And instead of green tinted foods and liquids, you're eating and drinking barium-infused foods and liquids. So all of this stuff helps paint a picture for us to try to understand what's going on. Probably the most common etiology of this kind of dysfunction that we see in the clinic is nerve injury. So there's actually there's probably more than two nerves that can be affected, but two nerves that can lead to these kind of symptoms. The first is the superior laryngeal nerve. which you can see it kind of overlaps with the thyroid gland here. So, you know, it can get pulled, it can get tugged. Typically, we don't see as much of this kind of injury in our office because usually the speaking voice isn't affected. You're talking fine. You tend to have more issues with getting loud or elevating your pitch, because what the superior laryngeal nerve does is creates tension in the vocal fold. And you need that tension to get loud, and you need that tension to make the vocal folds nice and thin so they can vibrate really fast. And that's what gives you a high pitch. So sometimes we'll have singers or professional voice users coming in with complaints that end up being superior laryngeal nerve injury. Then there's the recurrent laryngeal nerve, which is this guy here, kind of right in the line of fire. Your surgeons are probably monitoring that nerve during surgery so that they know where it is at all times and can avoid it. This nerve is the primary motor nerve for your vocal folds to open and close. And I'll explain more about that in a minute. But essentially, your vocal folds are a valve. They're a valving system. And, you know, they're open for breathing and they close to talk. And then when they close, that you kind of blow air through them, and that sets them into oscillation. And it's really, in that oscillation is what produces the sound. And it's just like a valve. And so if that nerve is injured, the vocal fold doesn't come all the way to center, and you have a leak in your valve. And it's that leaky valve that gives you a voice where you can't keep your voice going. So that's the kind of voice issue we tend to see to varying degrees with recurrent laryngeal nerve injury. Also, you know, if your voice box doesn't close, it can make it harder to swallow. And so we might see things like coughing with liquids. We don't, unfortunately, have any great treatments to make the nerve start working again. I get that question a lot. How do we get it working? It's not like a muscle where, like, I have a weak muscle, I'm going to exercise it and it gets stronger. Because in this setting, it's not about moving the muscle so much as the nerve is sort of the conduit to get your brain to send the muscle tone. And if that nerve isn't working, the muscle just doesn't get tone no matter how much you work it. So it's a waiting game. Usually if we're going to see some spontaneous recovery, we're going to see some improvement over the first 6 to 12 months. But in the meantime, there are some things we can do to improve voice function or swallowing function. So this is that valve I was telling you about. So this is a person with a paresis on the left side. So when she brings those vocal folds together to talk, there's this gap and it just leaks air. So one of our interventions is something called an injection medialization. I don't actually do it. A laryngologist or the head and neck surgeon does it. But if you look here, you're not going to see a needle, but the laryngologist is local anesthetized the neck and is inserting a needle into the vocal fold, and see it plumping up here, seeing it get nice and plump. What that does, it's a compensation. So now when the vocal folds come together, which you'll see in a second, here we go, no more gap. And when you don't have a gap, the valve is good. And, you know, it's not perfect. There are still some limitations, but the voice is stronger. It works a lot better and people are happy. There are other causes of hoarseness after surgery. It can be acutely, it can be from the intubation itself and some swelling. You know, we're still people with other problems. So sometimes it's like reflux that gets all the way up to your voice box. And sometimes it's something called a muscle tension dysphonia, which is what this patient had, it's sort of like a recruitment of swallowing muscles when you voice, and it's maladaptive. Oftentimes it's because a person has a problem with their voice box, which this patient does, and then they have to adjust, sort of spontaneously adapt to that voice problem, and they end up picking up sort of bad habits. They adapt in a way that kind of works against them instead of for them. So for this patient, you know, she was having this progressive hoarseness that had started a few years back. Her voice quality was variable. She had tightness in her neck. She had pain in her neck the more she talked, and voice fatigue. So we do our stroboscopy assessment here. You can see her vocal folds and her airway in the middle there. And in a second, if you watch the two vocal folds move, like back open and close, they're just not quite the same. The one on your left, her right, is a little slow. And so she was diagnosed with a vocal fold paresis on the right. You know, the question, of course, is this new? Is this old? Sometimes you can tell, and in this case we could, that this paresis is probably old. She's adapted really well. When you watch her voice here in a second, you know, she gets good closure, good vibration. So this doesn't seem like somebody struggling with a new condition. She's also squeezing a lot. So she was diagnosed with a secondary muscle tension dysphonia. Most likely, you know, she's had this paresis for a while. She's a teacher and a band instructor. Her demand is probably increased, and her, you know, not optimal voice pattern is what is giving her problems. So the recommendation in this case is voice therapy. And I'm going to sum this up here to say, you know, voice production is not just about your voice box. Voice box is an important part of voice production because it's the sound source, but voice production is a 3-system process. You have your respiratory system, your breath flow, that's sort of the gasoline of the voice car. And then you have your laryngeal valve, which is the phonatory system that produces the buzz. And then that buzz moves up your vocal tract, and that's your resonatory system. For most people in your everyday life with a functioning larynx, I promise you, unless you've been trained like voice technique, like an actor or a singer, 9 times out of 10, your larynx is your workhorse, your suboptimal breath support, suboptimal resonance, and your larynx is sort of carrying the load. But what can happen is once you have a problem with your larynx, that doesn't work so well anymore. And so voice therapy is really, most of the time, focusing on teaching you how to optimize your techniques. So you use more breath support, more resonance, take some of the pressure off your larynx, you know, so it doesn't have to work so hard, and clear up a lot of these symptoms. So with that, let's, so with this patient, she did 1 session of therapy with us, but she lived a good distance away. So she pursued therapy at home, and she's actually coming back next week for a check-in with us. So I don't know how she's doing, sorry to say, but she's coming back next week and we'll see. So I think now is maybe Q&A time.
Does anyone know of vagus nerve complications that could affect swallowing, speaking, and lead to dry, persistent cough after lung radiation? No sign of pneumonia any longer. Trying to find out some solutions. My team thinks perhaps the last bilateral neck dissection lung radiation could have triggered autoimmune. Also curious about any long COVID studies that coincide with issues. As brief a version as you can.
I mean, I have more questions probably than I have answers for this question. I think what I would say is, you know, injury to the recurrent laryngeal nerve can definitely have swallow effects, which I didn't talk a lot about. Mostly with what we call swallow safety or aspiration, like liquids going down the wrong pipe because of that leaky valve. You know, when you swallow, your voice box closes off your trachea so that the food and liquid goes in your esophagus instead of your windpipe. And when you have a glottis that doesn't close all the way, there can be aspiration. So in terms of long COVID, you know, there's a whole world of research and experts about long COVID, and I definitely do not consider myself one of them. And we don't see a lot of that in our clinic, so I don't feel like I can reliably comment on sort of how long COVID might tie into all your symptoms, except to say that I do hear, like on some of the listservs I'm on and things like that, that people do sometimes have voice issues and even some sensory or swallow issues related to long COVID. And then lastly, I think I would say that the recurrent laryngeal nerve, the vagus nerve, that nerve has a lot of branches. And sometimes when that nerve is impacted, it can lead to chronic coughing. So non-productive chronic coughing. And I don't know if that's in your picture, but it sort of came to my mind listening to the moderator ask your question. So I don't know if anybody has anything they want to add.
Yeah, quickly, I'll just add, yes, and any lateral neck dissection, the vagus nerve can absolutely be injured. And then as far as radiation to the lung, I imagine it can. Radiation does not typically give long-term damage to large nerves like the vagus nerve, but the dry cough, yes, absolutely, from vagus nerve damage.
And if there's mediastinal disease, that could affect the
Yes.
left vagus.
Right. The nodal disease, like extranodal extension. I mean, I recently cared for a patient whose disease was exiting the metastatic lymph nodes and sticking to the vagus nerve. We were able to free the disease from the vagus nerve. So dependent upon where the disease was stuck along the course of the nerve, you can have associated symptoms at that level. So just to say, and also even if you free the nerve and it's intact and the nerve bundle, right, if there was disease adherent to it, you may have function for a while, but if there is continued like permeation and sinking in of that disease, it can definitely lead to a late loss of function of that nerve.
Hi, earlier you mentioned SLN for singers. So I'm a classically trained coloratura soprano. I've noticed that my pitch isn't the same. And when I'm projecting, even in Zoom meetings for work, like I get tired after an hour. Do I ask my endocrinologist for a referral for, I mean, obviously referrals based on insurance, but would you recommend, what's your recommendation for a speech SLP or something else?
Yes, I'm so glad you asked this question. So I would recommend you find a fellowship trained laryngologist in your area. So if there's like a tertiary medical center near you or an academic medical center, beyond ENT, laryngologist is a ENT who specializes in the larynx. And the reason why I say that is because SLN issues are one of the hardest to diagnose. You need someone really experienced to help you with that. So find a laryngologist and they'll have an SLP on their team guaranteed and go from there. But it does sound like there may be an issue there.
Had hemithyroidectomy, stopped taking Levo 42 days ago, getting a full thyroid lab next week. How long does it take for all of the Levo to be out of my system for the best results from the labs?
Usually TSH takes about 6 to 8 weeks to stabilize it. So we usually do not check the thyroid hormone level right away. If a patient has a hemithyroidectomy, before it's a 50-50% chance that you may need a medicine, you may not need a medicine. If you have not taken the medicine prior to surgery, then we typically check the 6 to 8 weeks post-surgery, check the lab, then we decided if a patient needs medicine or not. But I'm not really sure the person who already started on medicine and I don't know why they decide to stop it. I don't know the question, but TSH level should be checked at 6 to 8 weeks, dose adjustment or stop the medicine. That's a typical time of the checking labs.
How does a BRAF positivity play into monitoring and transitioning into survivorship?
So we get this question a lot. There is a wide misconception that a BRAF mutation means that you have a more aggressive cancer. It's not true. If that was true, then papillary thyroid cancers by nature would be aggressive cancers because 70% of papillary thyroid cancer patients have a BRAF mutation, and it tends to be a very slow growing cancer. Are there more aggressive ones? Yes. So we don't look at the BRAF mutation by itself. We look at it in conjunction with other mutations. There are mutations such as TERT promoter mutations that put patients that make up for a more aggressive cancer. So we look at it with other mutations. The BRAF mutation by itself does not make for a more aggressive cancer, doesn't change our monitoring. The only thing that tells us, I mean, unless we're considering systemic therapy, that's a different conversation. The thing that it tells us in the majority of patients is that you're not as likely to respond to radioactive iodine. Patients with a BRAF mutation are more likely to be radioactive iodine resistant. So how do we use that information? If we're on the fence about whether or not to give you radioactive iodine, there are patients where we're like, well, either, we could not give it or we could give it. It's just, we're kind of on the fence. They're kind of borderline cases. In those cases, we may check a BRAF and if it's positive, then we may decide not to give radioactive iodine because they're not as likely to take it up anyways. But for most patients, we don't even check for a BRAF. Some places, I don't know, automatically do, but in most of our patients, we don't check for it. Unless we have a reason to, if we're undecided about radioactive iodine or if we're going to start systemic therapy and we need to look for targets. Those are the only reasons at MD Anderson that we would check it, at least with the oncologist that I work with. I don't know, other people might practice differently.
Yeah, we have so many patients, actually, BRAF mutated patient actually do transfer survivorship clinic. However, this is not gonna be the test result, and we will change our practice. This is a patient that if a patient has a progression of disease, and that if they need any systemic treatment like a chemotherapy, then if you are diagnosed with a BRAF mutation, then we can use a BRAF targeted actually medicine. So at that time, this is going to be important, but BRAF status will not change our management practice.
How does age factor into risk of reoccurrence?
It's a little bit difficult to say. Most of us here is we are adult practice. However, if you have a younger age diagnosed, and then that means that you live longer. Expected life expectancy is longer. That means there is a longer time of monitoring, and the close monitoring is also important too. Many of our pediatric patients, they have a very small lung nodules, 10 to 2 as well. And then sometimes it may be not directly, the pace of the disease, but then it's important to monitor, the right person, I mean, I have some patients actually diagnosed with their thyroid cancer and the young age, and that they actually had a surgery, and maybe they may not have the radioactive iodine. Then actually they said, oh, it was a stable disease, or maybe they said, oh, cured. Then they stop following. So which is not, I usually recommend, especially younger patient, because I mean, life expectancy, if you are diagnosed with 18 and you live until 100, right? That means another 82 years, so you're gonna be living, and that there's a recurrence chance can be.
I just wanted to add one thing to that. You may, if you're a younger person diagnosed with any type of thyroid cancer, you may feel like you have more aggressive treatment. But it really is just especially surgery wise is what I'm thinking, is because we know that we would have to watch you for years and years and years. And so sometimes people like to intervene a little bit earlier in younger patients in order to prevent you from having such close follow-up for such a long period of time. But that does not necessarily translate to your risk of recurrence. It just is a generalized, discussion between you and your doctors of how aggressive you want to be in treatment so that you can have a more relaxed follow-up schedule, basically.
Hi. I have two questions. One, I was really surprised to hear about a survivorship center. I'm at Hopkins now, and I've never heard of it. And before I was at WashU Barnes-Jewish, so it's really cool. But my second question is a follow-up to the BRAF question. If you have patients that have aggressive variants, like tall cell variants and hobnail features, how does that play with everything else? I know that's me. But yeah, how does that work with the other TSH and following them?
I'm not going to pretend to be an expert on the different variations of thyroid cancer. I know a lot more than many people, but there's still a lot of information that I don't know. There's always going to be information that people don't know. A tall cell variant, it's not a more aggressive variant. It just means that you have a BRAF mutation. If we have a patient with a tall cell variant, papillary thyroid cancer, all that tells us is that they have a BRAF mutation. 100%. All tall cell variants have a BRAF mutation. If we have patients with different variants that can give us some additional information about things to monitor for example, if we have a patient with a papillary thyroid cancer follicular variant, we know that those are more likely to metastasize to the bones rather than the lungs. because follicular thyroid cancer likes to metastasize to the bones. But as far as like monitoring, it doesn't really change our monitoring practices. We monitor the same. Typically our low risk patients, we monitor every 6 months for the first year. If everything looks good at a year, we move to annual appointments. Or if patients have active disease, we monitor every 6 months until we decide that it's been stable long enough to move them to annual appointments. But yeah, it doesn't typically change our management.